Assalamualaikum candidates. Today we are going to discuss on the 20 scenarios on hyperplasia. So the first is a 42 years old woman with menorrhagia, that is heavy menstrual bleeding, and biopsy shows an increased gland to stromal ratio without atypia. So you must remember that this is basically the simple endometrial hyperplasia. Then the second scenario is that a 55 years old obese woman with postmenopausal bleeding, crowded glands with atypia. So it means it is atypical endometrial hyperplasia, and you might be knowing that it has got a 30% risk of being converted into malignancy. Now the third scenario is that a male with difficulty in maturation and enlarged prostate with normal prostatic specific antigen levels. If the prostatic specific antigen levels are normal, then it means it is benign prostatic hyperplasia. Then a woman who is on unopposed estrogen therapy with an abnormal uterine bleeding. So it means it is basically hormonal induced endometrial hyperplasia, as in case of polycystic ovarian syndrome. Then the next question is chronic gastritis with thickened gastric mucosa. So again it is basically hyperplasia, and that is reactive in return to the increased acid exposure. Then the next question is a child with hemolytic anemia and splenomegaly. So here you see the splenomegaly is because of the hematopoiesis ongoing, and ultimately there is hematopoietic hyperplasia because spleen is leading to increased turnover of the RBCs in response to the hemolytic anemia. Then the next question is a pregnant woman with increased breast ducts. So she is pregnant. So you know this thing that in pregnancy there is physiological hyperplasia of the breast duct. So it is normal. Then the next question is enlarged lymph nodes during active inflammation, that is basically lymphoid hyperplasia. Then the next question is polycystic ovarian syndrome, patient with irregular cycles and thickened endometrium. So again it is estrogen dependent endometrial hyperplasia because in PCOS there is an unopposed exposure to estrogen. Then the next is a chronic smoker with thickened bronchial mucosa, here because of some pathogen exposure to pathological hyperplasia. Then the next scenario is cystically dilated endometrial glands on histology, basically it is simple endometrial hyperplasia. And the next scenario is basically related to kidney, that one kidney is removed, definitely there will be endocompensatory hyperplasia of the next kidney. Then you must remember that if there is back-to-back glands with minimal stroma, it is in case of complex endometrial hyperplasia. Then a man on androgen blockers with gynecomastia is basically having hormonal induced glandular hyperplasia. The next question is a long-standing anovulation with endometrial thickening. It is because of unopposed estrogen hyperplasia. Then the next scenario, it is not related to pregnancy, but just in case when there is iodine deficiency, the thyroid is enlarged, it is because of Guatter's hyperplasia. Then the next question is that hyperplasia is with atypia and loss of polarity. So here you see it is pre-malignant or atypical hyperplasia. Lactating women with enlarged breast, again it is physiological glandular hyperplasia. Then chronic skin irritation causing epidermal thickening is because of epidermal hyperplasia, that is acanthosis.